people on Zoom, people in the room, we will call to order the November meeting of the Douglas County Board of Health. For the record, there is a copy of the Open Meetings Act back on the west wall here in the legislative chambers, and there has been official notice of publication. With that, roll call.
Okay, Wade?
Yes, here.
Festerson?
Yes, here.
McNally is not. Rogers?
Here.
Weiss? Here. Jones? Wilkin? Here. King? No. Espinoza? No. Okay.
Okay. Item 2 is the approval of the minutes of the October meeting. Is there a motion to approve? Motion by Wade. Is there a second? Second by Weiss. Roll call.
Okay, Wilkin? Abstain. Wade?
Yes.
Rogers?
Yes.
King, Jones, Weiss? Yes. And Festerson?
Yes.
Item 3 is public comment. There is an opportunity for individuals on Zoom or in the audience to comment on items not officially listed, public health items not officially on today's agenda. Are there any public comment from anybody? Seeing none, we'll go down to item 4, and we have items A through W for approval and ratification. Note that item E should be removed because there's some more work needs to do there. And then from item R, for the record, the number on the agenda is incorrect. And Sunday, can you read the correct number in the record just so it's there for item R?
The correct number is 76009.
Okay, 76009. With that, is there a motion to approve the items A through W with the removal of E?
E and U. And
I
remove
thought
U.
it wasn't. Is it? Yeah. Without O, sorry, I need to stand on that. Thank you. The motion is to approve A through W, scratching E and removing O to go separate. Motion by Weiss. Is there a second?
Sir, I'm sorry. The letter U, it says agreement with UNMC regarding a student affiliation. The letter U, that one needs to be struck.
Okay, noted. With that change, there's motion, assuming Weiss still's motion. Is there a second? Second by Wade. Roll call.
Okay, Festerson?
Yes.
Rogers?
Yes.
Wilkin? Yes. Weiss? Yes. Wade?
Yes.
Item O is approval of a second amendment with Charles Drew regarding WIC. Is there a motion to approve letter O? Motion by Weiss, second by Festerson. Roll call.
Okay, Festerson?
Yes.
Rogers?
Abstain.
Abstain. Wade?
Yes.
Weiss? Yes. Wilkin?
Item H is Health Director's report and the issues of discussion. Dr. Hughes.
Excuse me, good morning. Have a few things to cover today. First of all, I wanted to just do a quick notification that we have hired a few new people on this month, and we're very excited about that. First of all, we have our new workforce development coordinator, which I am so excited for. This individual is going to really be that person who is able to work on trainings, finding professional development, really supporting our workforce in the things that they need to be successful, and of course helping leadership to be successful as well. We're very excited about this. We haven't had a robust orientation program for new hires for a really long time, and so that is something that this individual will be doing, and so we are very, very grateful for her. We also have brought on our accreditation coordinator, so that person is now actually working in the office, and we were able to submit our application for accreditation about a week early. Is that right? So we are very, very grateful for that, and we are well on track to achieve our accreditation. So third time's the charm. We're gonna do it. We're gonna do it. It's gonna work out great this time. We're really excited about that. I also wanted to let you know that I should probably have asked you if you are cool with this, but I'm so proud that I have to brag, even though it's not really my achievement. But Jamin Johnson was able to successfully defend his dissertation last Monday. And so we are very proud of him for achieving such a huge thing in life. Earning your doctorate is something really special. So we're very proud. Congratulations, Jamin. Okay. I wanted to take some time to update you on the rabies situation that you got to hear about the last time we gathered a month ago. So the community has kept us very, very busy over the past month and a half or so. The first issue we had, as you know, was rabies. You had the CDC here last month to talk to you. For the most part, that situation has wrapped up. So if you recall, we had a kitten that was diagnosed with a kind of odd strain of rabies that you typically don't see here. And that really spurred a very large response to ensure that raccoon rabies is not actually established here in Douglas County. That was really a three-pronged effort. So there was surveillance happening, which is basically testing dead animals to see if rabies was present. That's actually going to be ongoing until probably anytime between December and February. They have a certain number that they want to be able to test, between 400 and 600 specimens. So right now I think they're sitting at around 200, so they've got a little ways to go yet. And that's going to be, the testing for that is going to be transitioned over to the UNL Veterinary Diagnostics Center. And I think that transition happened last Monday. And then we had the Trap Vaccinate Release program, which is where we put traps out that were baited. We were able to trap raccoons and a few other little critters and vaccinate them manually against rabies. They were able to vaccinate 753 raccoons, 41 skunks, 4 cats, and a fox. So that was a pretty successful effort. And then there was the oral rabies vaccine campaign, and this was the little, I call them raccoon ravioli because of the stuff they put on the outside. It looks like it's breaded like a little ravioli, but basically little vaccine packets that were put out all around town in about a 64 square foot or square mile radius, not square foot, that'd be really ineffective. And basically they put out about 18,000 of those little raccoon raviolis, and that was an incredible effort by a number of organizations that kind of came together to go out and get all of those little packets placed out in the community. So that was very successful as well. So far, let me see if I can, 206. So far, for all of the animals that they have tested, we've had 0 positive rabies. So that is excellent news. We hope it stays that way. So at this point, it's looking as if that kitten likely was imported here, maybe from somewhere on the East Coast, and that we don't actually have it established here in Douglas County, which is what we want. So I think that was a very successful campaign. There were a number of organizations and agencies that came together to pull off that huge activity, and we're so grateful to all of them just for their expertise, for their willingness to help out and be part of that effort in order to protect their community. We could not have had a more smooth and well-run event, so very grateful to them for that. Does anyone have any questions about raccoon rabies?
Lindsay, I had to say, as you were noting there, that it was quite the mobilization by you and your staff and multiple agencies, and I commend you for doing that so quickly. Kind of a case in the importance of public health, right, that people don't always think about. Yeah. So in your current status assessment there, is it I know testing's ongoing, but is it safe to say it's not established, or just that's the designation so far?
I am cautiously optimistic that it is not established here in Douglas County. I don't want to, say for sure that it is not here until they've had more samples tested. But at this point, it's looking pretty good. Our big variants here are bat rabies and skunk rabies, and I think hopefully it's going to stay that way. So far, it's looking really good.
Will there be a point in time where that's an official designation?
Yeah. As soon as they're finished with that component of this response, so the testing component, the surveillance that's being done at UNL Veterinary Diagnostic Labs. So once they feel that they have tested sufficient samples to say, okay, this sample is pretty reliable, then we can say with pretty good certainty that it's not here. So between December and February, the weather impacts how many animals are out and about, and so that can either slow things down or speed things up depending on what they're able to get their hands on.
Okay.
Yeah.
And then a funny story I told Lindsay before the meeting, my beagle found one of the packets you were describing there and chomped on it a little bit, but as advertised, it was harmless to pets and other animals, so he's fine, and I appreciated the information you had on your website about that.
He just got a little booster.
Yeah. Thank you.
Anyone else?
All right.
Is that it? Okay. I think that's all I have for you today.
Then let's just transition into item 6 in the presentation on tuberculosis.
So the CDC left our conference room on the 3rd, and on the 6th, we had another great big public health emergency rear its head. So not much of a break there. And let me get this pulled up because I want to make sure everybody's on the same page with what's going on here. Okay. So, on the 6th of November, we received a positive lab for an individual who was suffering from symptoms of tuberculosis, and those lab results, unfortunately, were positive. It's not completely unheard of in our community to have active cases of tuberculosis. We get about 15 to 20 a year that we typically will investigate. If you think about how we used to do the contact tracing with COVID, that was not a new activity for us. We've been doing that with tuberculosis and other communicable diseases for many, many years. So as soon as we got those positive labs, we initiated a contact interview. And unfortunately, we were notified that this person had spent multiple days and times in the Westview YMCA Child Watch area. So Child Watch is a little different than your typical daycare setting. Typically, in a daycare setting, what you see is people enroll their children to a classroom, and it's the same kids that are there every single day. Drop-in care works a little bit differently. So this is basically a child watch that members of the Y are able to bring their children and drop them off in the child watch area for a couple of hours at a time while they go use the facility however they choose. So that means a lot more people in and out of that area. So all said and done, we were able to identify around 550 children and staff that were exposed to this active case of tuberculosis. Typically, we don't get that many exposures when we're doing one of these. So what makes this particular instance kind of unique is really the scope. We're very, very many people that we are having to work with on this to ensure that they don't have tuberculosis. So I'm going to give you just a really, really quick overview of tuberculosis, just because it helps, I think, for you to understand how we go about responding to this. So tuberculosis is caused by a bacteria, and it usually affects the lungs. However, it can attack any part of the body. So typically we see pulmonary, but there are times when you see it in other parts. And with children, especially young children, you can see this progress to kind of a disseminated disease, or a disease that is throughout the entire body or in other organ systems fairly quickly. So in this instance, it made it very important that we respond very quickly because we had a number of small children involved. Not everybody who is infected with tuberculosis actually gets sick. So tuberculosis exists in a couple of different forms once it infects somebody. There's latent tuberculosis, and in the latent form, you're almost like a carrier. You've got it in your system, but it's not making you sick and you're not contagious to other people. Where we worry is when it's an active tuberculosis infection. So once it's a tuberculosis disease, then you're symptomatic and likely contagious to other people. And TB is fatal, or can be fatal if it's not treated, especially in children. So again, that kind of gave us an extra layer of importance in responding to this. It spreads through airborne droplets, and they're expelled when a person coughs, sneezes, shouts, sings, talks, things like that. And then, of course, another individual who's in the area could breathe in those droplets. It is not quite as transmissible as something like COVID or the flu or a lot of those cold viruses that are out there. It takes a little bit longer, more close contact to spread it to another person. So we typically say that if you're in an environment with someone who has active TB disease for 30 minutes or more in an enclosed area, and if you're having face-to-face contact and things like that, we would consider you an exposure. There are a couple of different ways that we figure out how someone, or if someone has tuberculosis, so we're able to test in a couple of different ways. One of those is the PPD skin test, or TB skin test, and a lot of you, if you work in healthcare, you have probably had more than one of these done. And basically this is some fluid that contains dead bacteria from TB that's injected underneath the skin. And you wait a couple of days to see if a lump forms under the skin where that was placed. And if a lump does form and it's more than 5 millimeters, we consider that a positive. If there's no bump, you're not positive, so that's good.
Dr. Hughes,
yeah.
You may need to minimize that box.
This one right here, sorry about that.
Or minimize the whole gallery over
I did on, let's see. Better?
there. There you go.
Okay, sorry about that. There is a vaccine for tuberculosis. It is not in use in the United States. It's in use in other countries, but we do get a number of people in the United States who have had that vaccine, and that can cause a false positive on these skin tests. The other way we test is through a blood test. It's an IGRA, and basically you collect 4 tubes of blood. Those results are usually ready within 24 to 48 hours. The nice thing about this is we can test people who've had that vaccine and get a more accurate result. Unfortunately, we can't use it in under 2 children, and so we have to place that skin test for all of those really, really young exposures. Now I'm going to click on the wrong one to try to advance my slides. All right, so like I said, we had a case that was identified. We had a large number of exposures that we needed to work with. So like I said, we immediately started a case investigation to identify contacts. Once we knew where this exposure had occurred, we were in contact with our medical consultant, Dr. Neiman, with the YMCA where this occurred. We brought in DHHS. We called the CDC and consulted them with our plan just to make sure we weren't missing anything. Nebraska Public Health Lab and Children's Nebraska. We work together to identify, notify, educate, coordinate, test, and treat over 550 people. So that's an ongoing effort so far. I can't give you an exact number because our clinic literally just started 20 minutes ago. So I don't know how many kids they've seen yet, probably about 6. But at Children's Nebraska held a clinic over the weekend where they were able to test 270 children. And most of those children are more recent exposures and very young. So they're ones who would need something called window prophylaxis, which I'll cover here in just a minute. But if Children's had not been willing to step up and help us with that, we would still be maybe 50 kids into this effort, just because of the complexity of when you have these littles come in. It's not just placing a test and sending them home. They get an entire assessment. They get that test. They get chest X-rays. It's a whole thing. And so we are so incredibly grateful to Children's for helping with that effort. The kids that are a little bit older and maybe have later or older exposures are coming to our clinic, and they don't require quite the same level of testing. Those children were able to just test, read those tests, and then they're finished. So our side of that response is not quite as complex as Children's was. We did stand up our incident management team right away to manage our response internally. Our response has touched almost, I think, every section in our department. We've utilized people to man our call line. We've had people making phone calls out to patients. Very grateful just for how quickly the IMT was able to get things moving so we could get these kids taken care of. We also work to identify resources, and this is an ongoing effort. So as you can imagine, this is an extremely expensive response. Especially when you're talking about a lot of clinical care and medications, the costs add up very quickly. And so we have tried to minimize the costs where we could in terms of, asking for assistance from other health departments, things like that. But we also know that there's going to be quite an expense to this. So we're working to identify funding. DHHS has been wonderful in helping with this, so ensuring that kids that are not able to pay for, or families that are unable to pay for testing and treatment and things like that, there's an avenue out there. But we're still working through what all of that looks like. I did do an emergency declaration, so a declaration of a public health emergency. This is administrative. This isn't asking anybody to do anything. This is really saying, hey, this is a problem that we have in our community. It's big. It's a big deal. The scope is large. And hopefully that will smooth the way for any resource requests going forward. Like I said, we expanded our information line. Very grateful for the staff that were able to just jump in and who volunteered to give up their holiday on Friday to come in and answer those calls. So we were able to get letters out only a couple of hours before we had a parent listening session. So we knew that there was going to be a number of people out there who had questions and needed answers who were not able to attend that listening session. So it was really important to us that we had that information line up and moving the next day so that people could still get their questions answered. And that went really well. And that moves us into today. Today we are initiating our own pod testing clinics. So pod is just kind of the format that we use. So anytime we have a public health emergency and there's the potential that you might need to administer medications or vaccines, or in this case testing, you can set up kind of this point of dispensing is what we call it. And it's a great way to get people in and through in a very organized way. And I'll show you that here in just a minute. And I'm still clicking on the wrong one. That's funny. If you've ever wondered what it looks like to respond to an emergency on the public health level, this is just the first page of our objectives. So when we stand up an IMT, one of the very first things we do is sit down and figure out, okay, what needs to happen? What do we need to do? Who needs to do it? When do we need to have it done by? So it's a very, very organized approach to response. And so our ERCs set this up. And like I said, this is only the first page. I didn't think you really wanted to see the whole thing, but I did want you to just visually get an idea of kind of the complexity and the fact that there's a lot of work that goes into one of these clinics or one of these responses. So talking just a little bit about contact investigation and the testing that we're doing. So we have two cohorts. We have the cohort that went to Children's. We have the cohort that's coming to us this week. So children who were exposed prior to August 21st, so that was going back to like May, they will get, depending on their age, either the skin test or the blood test, and they only need one test, and they don't have to take any kind of prophylaxis. And the reason for that is enough time has passed that their immune systems would have responded to any pathogen. And so if they're not testing positive, there's no reason for them to be on medication. We can be pretty certain that they don't have tuberculosis. However, the children who were exposed before August 21st, or after August 21st, I'm sorry, will actually need two tests. So what we've seen through Children's was really the first step, if you will, and because it can take up to 10 weeks for a body to essentially respond to a pathogen that has this particular pathogen that has infected them. And so even though we are testing initially to see if there is disease there, we may not actually know until about 10 weeks later. So they get another test at 10 weeks. We want to minimize, especially for these kids, the probability that they will develop active disease and severe disease. And so we put them on something called window prophylaxis. And basically what this means is that they take an antibiotic that's very specific for tuberculosis it depends on when their exposure happened. So it can be several weeks that they would take that window prophylaxis, and then they get that retest. This is just kind of breaking that down a little bit more in case anyone has any more in-depth questions on how this happens. This is, I think, what we gave to, basically what we gave to parents so that they would understand what they were getting, where they were going, and things like that. This is just a little bit more on that window prophylaxis treatment. So we're offering that to children under 4. And this was the reason that Children's held the clinic, because they were seeing those littles with those more recent exposures. And they had a team of pediatricians on hand that were able to, figure out the dosage and the length of time that the child needed to take the medication and all of that. So they are the ones who will be monitoring that. And like I said, it's really just a way to prevent severe disease from developing in these kids. This is what our TB pod testing site looks like. So if you go all the way over to the right, you can see where the greeters are. Patients come in, they register. There's a waiting area. We're actually separating them out by age because we know if they're 2 and under, they're going to get that PPD. If they're over that age, they're going to get the blood test. So we have a number of stations that are set up for blood test and a couple set up for PPDs. We got phlebotomists, and PHL helped us to identify phlebotomists to come in and do that. So drawing blood on kids is not something that just anyone can do well. And so we did ask for some phlebotomists that have pediatric experience. So we're well prepared there. And then we have nurses doing those PPDs at the PPD station. And then when they're finished, we'll have them wait around just a little bit so we can make sure they're doing okay. They get snacks because, I mean, if you're going to get your blood drawn and you're a little kid, you need a snack, right? Snacks and stickers is where it's at. We were also able to bring in a behavioral health therapy dog to have in the area. So as they come out of getting their blood drawn or getting that PPD, we have a small comfort measure for those who might benefit from that. And that's it. And then they're out. So it's a pretty organized way to do this. This is happening at that YMCA. We figured if parents brought their kids to the YMCA and left their kids at Child Watch, maybe this would be a convenient place to do this. They have a beautiful gym, so they're allowing us to use that gym for 3 days. We're very, very grateful for that, and I think the parents are too, because it makes things much simpler. So this is just kind of a summary, what we know so far. 270 children were tested at Children's over the weekend. Yesterday, I heard that we had at least 150 results back. Our nurse had read, I think, 20 PPDs when I got numbers. So far, all of those were negative. So that is excellent news. However, keep in mind, this is the young cohort that needs, and the more recent exposures that are going to need that second test. So we're very glad that they're negative. We're going to hope that they stay negative. We are continuing to work with the case to ensure that there is no person left behind in terms of identifying any other people who might have been exposed. And if we do identify more people, we'll of course offer testing and treatment as appropriate. And like I've said, we're doing our testing from 9 to 3 out at the YMCA today, tomorrow, and Friday. All right. Any questions about TB response?
So just one question. You're talking about how TB can be latent in the system. If you have the latency form, can that eventually turn into active?
Yes. It can if you've never been treated. So if a person has latent TB, they don't know that they have it. Something happens that just kind of knocks their immune system down and allows basically that tuberculosis bacteria to activate, and they can then convert to an active disease. We want to prevent that from happening. So when we identify those latent cases, we put people on a course of medication for several months, and that really knocks that risk of converting to active disease down to almost zero. So it's very, very effective. It's probably one of our best control tools that we have for tuberculosis in public health. So yes, the answer is yes, it certainly can and does happen. I myself have investigated several cases where that's exactly what happened, is they just didn't know that they had a latent infection. Their exposure was maybe 10, 20 years prior, and then something happened that their immune system just didn't keep it suppressed, and they converted to an active disease.
Maybe just one similar follow-up question to the previous topic about the rabies. Is there a point, you're just starting testing now and you've contained the population that we think has been exposed? Is there a point in time where you'll be able to anticipate declaring the next comment on the public health emergency?
Yes, I think so. So really, once we have done the bulk of the the testing for the kids and any other exposures that might come to light, then we can feel pretty confident in saying, we did or didn't have any spread that occurred from this. I do want to put out there that kids are not great spreaders of tuberculosis. It's kind of the opposite of like every other disease. I feel like kids are like, they spread disease very easily sometimes, especially respiratory diseases, just because they're playing together, they're face to face, it can be very easy. But tuberculosis really takes some prolonged exposure, and kiddos, for whatever reason, just are not as good at spreading it as adults are. So, the hope, of course, is that even if we did have some kiddos that maybe we identify with latent disease, it's not going to activate, it's not going to spread beyond that. So I feel really good that it's probably not going to result in like an outbreak situation. We certainly may identify some other latent cases, in this cohort. And if we do, again, we'll put those kiddos on medication that will knock their risk of ever being contagious to other people and being sick themselves down to almost zero. But yeah, there will be a point. It'll take a little bit of time, several weeks before I can say with certainty that we're good.
Thank you.
I just wanted to express gratitude for the response of the health department. Your staff did an amazing job. Appreciate the presentation, answered a lot of my questions. So thank you.
Thank you. And thank you to Children's for, I truly cannot say enough about how grateful we are for their effort, because pulling this off in the health department alone would have been just an incredibly hard lift.
Okay,
All right.
thanks, Dr. Yee.
Thank you.
We'll go on to item B, which is the next report for community benefit. And we have with us Methodist Hospital today.
I'll make sure your presentation's up. Where is it? Oh, got it. Silly me. Sorry. I was looking for the PowerPoint. There you go, Jeff.
I use page up, page down on the keyboard. Will that work?
I think so.
I'm gonna test something here real quick,
Okay.
Or not.
or not. Let me try this. There we go. Okay. Good morning.
Good morning.
My name is Jeff Prohaska. I'm the Chief Strategy Officer for Methodist Health System. I'd like to thank the board again for having me to come share, and mostly an update on Methodist Health System's commitment to the community. Before I start, I did want to make an introduction. I have with me Steve Jackson, probably a familiar face to many of you. Steve's a new member to the Methodist team. Very happy to have him and his decades of experience and his commitment to the community, which aligns very nicely with our mission and with our efforts to really be committed to our community. So I wanted to start with that mission. It's a consistent message that Methodist has had and what we have used as our reason for existence, and that is improving the health of our communities by the way we care, educate, and innovate. And like most mission statements, it's very carefully crafted. It says a lot about us and our purpose. Number one, focusing on the health of our communities, not just being a hospital in the business of taking care of sick people, really being committed to improving health. Communities is plural. We are a regional health system. We are largely focused, the majority of our footprint is here in Douglas County, but we exist in Council Bluffs, so Potawatomi County. We're in Mills County in Iowa. We're also in Dodge County in Nebraska and Sarpy County in Nebraska. And each one of those brings a local commitment. And we strive to be that committed partner, and I'm gonna use that term a lot of times in this presentation, partner within each of those individual communities. The terms care, educate, and innovate are what we aspire to be. We think that care embodies the culture of Methodist, our people. We educate. We have a couple different responsibilities there. One is to be health educators in the community, to make people more literate with their health responsibilities, to understand how to improve their own health. But also, and we'll talk about this a little bit later, the great challenge in terms of healthcare workforce in our community. We have to be committed to building the future of healthcare and providers of healthcare in our area. And we take a very firm stance on our role to educate those folks. And last, innovation. Times have been very challenging for health systems around the region. We feel that a strong emphasis on innovation will allow us to come up with new and creative ideas on how to solve those challenges. We're very proud of our mission statement. We try and live that every day. So I'm going to begin with a format, if you will, on how we're going to go through the presentation. We're going to take a little bit of data from the community health needs assessment. This guides us. This allows us to focus on the real needs of the community. We do this every 3 years, and we do this in partnership with the other health systems in town. A very important effort to understand what the needs are so that we're focused on those needs. And the first one, and the primary one, and really the one that leads all of us, is access to health care. And I pulled this particular piece of data because it's our duty, it's our responsibility as a healthcare provider in the community to make sure that there aren't difficulties in accessing care. And obviously in Douglas County, as we compare that to the metro and to the US and also the trended data, we do have some challenges. It's affordability, it's transportation, it's convenience, it's location. You know, all these things stand in the way of the folks getting the care and the access to the care that they need. And it's our role to eliminate those access challenges. So I want to first put out our footprint, and you'll see it's heavily weighted in Douglas County. And this is just to say that we are present. You know, these are bricks and mortar locations that Methodist Health System has put in place to take down those barriers to access. We have a scheduling process where, yes, you can call and book an appointment, but you know, when I talked about those challenges, I referenced convenience. You know, when people are sick and they need to come see their provider, they want it to happen now. And I think one of our biggest pieces to be committed to the community is to be accessible. And we're changing our processes to allow for urgent cares, immediate cares. So urgent care would be you just walk up to a standalone site, which acts as an access point. We have several locations where we have a standalone urgent care. One's coming downtown here, opening in December. But the immediate care is any one of these clinics. We have set up processes where we don't have to require a scheduled appointment to come in and see us. To be available to the community so that they can have an access point convenient and proximate to them. Also, it's a difficult navigation process to access your physician oftentimes. We tried to make that more convenient for the community and give them a single number to call. I don't know where to go. Who do I call? 354-CARE. You're speaking to someone has access to schedules from the entire region and can find an access point for you to access the care that you need. Every one of these locations, as part of being a tax-exempt organization, does have a financial assistance policy. I mentioned one of the barriers to access was affordability. We need to take down that barrier, and we do. We deploy these financial assistance policies at any point of care, and we'll continue to do so. Now's where I point to some of our innovation. That was pretty standard operating procedure for a health system to put clinics into the community. Where we wanted to be innovative was take care to the people, not by necessarily bricks and mortar in all instances, but to be creative. The first one I wanted to highlight is a new initiative that we are partnering with an organization of volunteer providers here in the community called Heal Omaha. Heal Omaha is a team of street medicine providers with their backpacks and care devices inside those backpacks. They are in place to engage patients that are homeless, that have come through our emergency room. And it's an intimidating environment, and a lot of times those conversations within the emergency room don't always go as a trusted advisor. We wanted to break down those barriers of communication and put together a team that can go out into the community, into the places where these people, where they are living. It might be under a bridge, it might be behind a retail center, but we're finding them and we're engaging them in their environment to have some real healthcare conversations, all with the intention, again, back to our mission of improving health. The next one is our Mobile Diabetes Center. It is a coach, it is an RV, and it is to take care out into the community. We partnered with Douglas County Health Department with this initiative a number of times, primarily through lead screenings, but through the time of the pandemic, we also used this vehicle to deploy care into the community. It's in place for screening, it's in place for education and delivery of care. Also wanted to announce that this year, most recently, we have added a new coach, so we have 2 mobile diabetes units. The second coach is a little bit more nimble. It's a Sprinter van. It doesn't require a driver with a CDL to operate, so we can get into a lot more places, and it's a bit more convenient to deploy at a moment's notice. We're really proud of our Methodist Community Health Clinic in partnership with Coos Memorial Lutheran Church. And we have an actual free and reduced fee clinic located at a site of need and is adjacent to the Coons Food Pantry and also the Healing Gift Free Clinic. So we have a very high traffic area of people of need. It's in a location that they're very familiar with, and it's convenient for them, and they're accustomed to going through this location. We're using this really in what we call as a hub for collaboration. This is a place where we can go and we can partner with providers and other social organizations in the community to offer screenings and education in a place that people are accustomed to going to. I think I might have reported last time when I came to the group that we were piloting a screening for social determinants of health at this location. That was our pilot. We have now moved into deployment. We were very successful at the Methodist Community Health Clinic in learning a lot about screening for social determinants of health. So much that we are now deploying that across the system to all of our points of care, whether that's in the hospital or ambulatory sites. And what we learned at the Methodist Community Health Clinic was a couple things. One, screening for it is not always the most difficult thing. Asking a question is really all that pertains to. What's difficult is what do you do when they say yes? I experienced that challenge. That is a barrier for me. Now, it's our responsibility to eliminate or reduce those barriers. Our process for creating referrals to resources and developing partnerships with resources in the community so that these patients can seek and access the benefits that come along with the resources in the community, that's the challenging part. A lot of communication has to occur. A lot of data sharing between our EMR and their systems has to occur. There's some wonderful partners in the community that are standing up solutions for that, and we're working with them in order to exchange health information in a safe and private and confidential manner, all with the purpose of really helping these people out, reduce the barriers that they're experiencing, and then trying to reduce the barriers. Using that data of what we're accessing and what referrals we're making and what successes are accomplished, we can use that data to then put in policies, procedures, and processes, more relationships in the community in place to manage the health of the population. So it's a big, big process. And we know there's a lot of emphasis on social determinants of health. Health systems, I think, are they're finally getting their stride on their role of where we belong and what we can fix in terms of these solutions. So a lot of work happening in social determinants of health. More specific, some disease states. Also identified in the community health needs assessment was cancer. It floated towards the top in terms of mortality. Where we struggle, specifically in our county, is our comparative data between age-adjusted mortality at the local level to the national, and we do have a higher mortality rate. And our role as a healthcare provider is to help that, is to reduce the overall mortality of cancer, and we do that in 3 different ways. One is early identification. It's screenings. If you can catch cancer early in the process, you've heard stage 0, stage 1. If you can catch it early, oftentimes your survivability, let's flip the wording there from mortality to survivability, is much greater. And these screenings are very, very important. And we know that not everybody screens exactly as they should. So we have a couple different roles. One is to make screenings very, very easy for people to access. And we've been innovative and we've been very partner-driven on finding those places where we can offer those types of screenings. And we've also been very targeted. Our role, we feel, in terms of excelling in cancer care is going to be in your solid tumor cancers. It's essentially a surgical process. If we can excise or cut out surgically the cancer, that's our forte. The bloodborne cancers, we know there's foremost experts in the community on that. We feel that it's appropriate to be very good stewards, if you will, of the process so that we know what we're best at. And that's what our screenings are going to focus on, and that's how we're going to be great at identifying these cancers early for folks around the community. We also know that there's some behaviors that can cause cancer, and it's our role, it's our duty to go out and promote and to educate and to let people know the correlation between certain behaviors, tobacco use, HPV, the correlation between those and many different solid tumor cancers is absolutely direct. And if we can modify some of those behaviors, then we can reduce the prevalence of cancer and thus reducing the mortality from cancer. The last one, we also know that there's a direct correlation between hereditary risk and cancer and thus mortality from cancer. So putting in place genetic testing and hereditary risk programs and helping people understand somewhat confusing results. It's very data-driven, very intricate, so we have counselors to help them understand results of that and then also recommend therapy and make referrals for treatment. Innovation, again, taking services to people where they are. We recognized a low breast screening rate for our communities. As indicated, women should have a breast screening at certain times in their life. And in our community, they weren't, generally speaking. The data would suggest that we had to improve our breast screening rates. So one of the innovations we came up with was making it very, very convenient for them. We created a coach based really off of our experiences with that mobile diabetes unit, that if we come to you, you're more likely to take advantage of our services, that you're more willing to participate. So we kind of bifurcated this process. One, we have many great community partnerships where we offer the pink coach, if you will, our 3D mobile mammography unit to come and locate itself at One World, at Charles Drew, at Completely Kids Latino Center, All Care in Council Bluffs, NOAA, North Omaha Area Health, and the Intercultural Senior Center, and park that bus there and see people for screenings. The thing we're finding is that particular population within those partner groups has a very low adherence rate to getting the breast screenings when they are indicated. In fact, we measure when's your first time you've received a 3D mobile mammography, and we asked, is this your first? 32% of the people that came through this device in those community locations said that this is the first time I've had one. So it's making an impact. It's getting people in when they probably otherwise wouldn't. On a more wider spread note, we have a number of partnerships with locations around the community in terms of large employers, small employers, where we have people, HR departments that are very interested in their employees' health. And they want to increase the screening rates for their employees. So we're partnering with employers around the community and essentially going and parking in their parking lot and taking scheduled visits for their people to come down and get mammographies. Shifting gears to heart disease and stroke, we have a prevalence issue with heart disease in our community. Rates are higher than the U.S. and trending in the wrong direction for the metro. So we want to focus on the care that they receive. And a lot of that has to do in terms of heart disease. In the event of a heart attack is how quickly we respond and how accurately we respond. Working with partners like Mission Lifeline, we lead in this space to make change. We want to make sure that people, upon a heart attack, are taken care of in the most appropriate manner and that they receive the care that they need as quickly and as accurately as possible. This is standard protocol. They are developing, our physicians and our providers are helping develop these protocols to ensure that the EMT squads and the hospitals, the emergency rooms, are well equipped and knowledgeable of the processes that are most likely to help these patients that need that care. Screenings are important, hypertension, blood pressure. We're in the community doing those types of screenings. And then unique to us, I think, with our role in women's health, with a specialty hospital focused on women, Methodist Women's Hospital, we found a nice dovetail, if you will. A lot of synergies exist between Go Red for Women with the American Heart Association to spread awareness and education and knowledge about heart disease for women. Also parlaying our role as a specialty women's hospital with a very large birthing population, we have a role, if you will, in infant mortality, which is something within Douglas County and the metro area where there was identified need. That need was, as the data suggests, that our infant mortality was trending in a direction opposite of the U.S., almost polar opposite. When you look at the graphs, it looks like we've improved over the last several measurement periods, which is great to see. But obviously, there's some factors at play there, and we feel it's important that we emphasize that we focus on that improvement. So within infant health, I want to first start off with a little bit more of a regional approach. Birthing deserts is a challenge being in the Midwest with a very disparate population. The population rural versus urban. It's driven purely by population, but just the number of deliveries that exist in a rural setting are a lot smaller than they are in an urban setting. I guess the math makes sense on that you would expect it. But with that comes the competencies and skill sets necessary to remain competent. If you're not doing a whole lot of deliveries, you're not going to be as competent, and hospitals across our region are recognizing this, that it's becoming unsafe for some hospitals to maintain their delivery programs. Oftentimes the obstetricians who are specialists in childbirth are not locating in rural areas. They're moving to more urban populations, leaving family practice physicians with not a lot of experience or even emphasis on childbirth. So when that occurs, you have a dearth in childbirth. When a woman goes into labor, proximity is key. You need access close. And what we're seeing in these rural populations is a lot of that dwindling. So our maternal fetal medicine group, which is actually the largest in the region, has a real charged approach to affecting birthing deserts, to supporting rural hospitals to either one, move that care to the hubs, which are slightly more populated but still rural, or boosting programs out there through education and knowledge sharing in terms of OBs, obstetrics and deliveries. Community education is a big piece as it pertains to infants and their health. Pregnancy and childbirth classes being offered in the community is something the Methodist does. Parenting and taking care of infant classes and education is going to be a big piece. A leadership role in terms of promoting breastfeeding and the impact that has on the health of infants. Consults and support groups is one thing, to be able to bring people together and learn about the benefits of breastfeeding, but actually facilitating it for those that can't breastfeed. We do serve as a depot, gathering milk from mothers, donating that milk, and then sharing that with those that can't produce. So really facilitating a process that's necessary. And then again, hearkening back to our involvement in genetic testing, I believe you're probably, through the course of these presentations, the next decade, you're going to hear a lot more about genome, about genetics, and its impact on health. So here specifically in terms of pregnancy and newborns, genetic testing for health there. Sexual health. We've been seeing this on the community health needs assessment as long as I've been involved, which is in the early 2000s. So we know that there's something in our community that needs to continue to improve, and we need leaders in this space. Again, parlaying our position with our specialty women's hospital, we've leveraged that to build out some access and some good information and education for people in the community as it pertains to sexually transmitted infections. We've been partnering a long time with the Douglas County Health Department on this. We're going to continue to do that. We've actually stood up some bricks and mortar programs in the sexual health space. One of them is a clinic where we do offer assessment, diagnostics, and we offer treatments in the space of sexual health and promoting healthy sexual behaviors. We partner for some free testing, confidential testing for sexually transmitted infections. That's located at the Women's Hospital. So it is something in the community, partnered with Get Access Granted, to make it easy for people to test so that we can stop spreading. One of the pieces of our line of business is we see things and we experience things, one of which is difficult. It's sexually transmitted diseases that come by the way of sexual assault. Our Sane Start program, which is located in every one of our emergency rooms, is a specialty program for helping the survivors of sexual assault. Unfortunately, some of those cases do involve sexually transmitted infections, and we treat those, we manage those cases for those survivors. Mental health. Another issue on the community health needs assessment, a definite need in our community. I want to talk a little bit about some of our efforts on how we're going to be and have been addressing our mental health challenges in our community. Number one is what we call swimming upstream. Not a novel concept, but it's the idea that if we can tackle some of these challenges when our community is young, that downstream effects can be mitigated and that we can really help people out. And we can improve the entire community by doing it early. With that, we have the community counseling program, the Methodist Community Counseling Program. It's located in every one of the OPS high schools and every one of the OPS middle schools and every one of the OPS alternative programs. We have a new location we're helping out at Metro Community College, and we're also in some neighborhood churches. These are licensed mental health practitioners focused on the behavioral health needs of our youth. Last year we served over 1,000 people, and also last year I was asked Commissioner Rogers that what were they presenting, the top 3 reasons that they were presenting with. Did some research, and for you I found that it was depression, anxiety, and behavior problems. Again, in the concept or the idea, the theory that if we take care to people, that it will be more accessible and more appropriate, that it will be more successful. Our no-show rate amongst this population is 10%. Double that for most behavioral health counselors. We make it real easy. We put it in the schools. They are a hallway away. When a teacher has a problem, when they recognize a kid might be struggling with those types of issues, when a school counselor who's not necessarily focused on the mental health, but maybe the health of the overall child, notice that there's a specialist right down the hall that can help these kids out. So becoming very comfortable in the school environment has been, I think, one of the biggest wins of this program. They're working with social workers within OPS. A lot of partnerships across the community. We know that there's a lot of effort in Douglas County focused on this particular need, so we need to be at the table and we need to be partnering with them. One, I guess, logistic thing with this program is it's based in the schools, so what do we do in the summer? We recognize that the needs don't stop in the summer. Those behavioral health needs still exist, so we decided to form some partnerships and some access points within the Boys and Girls Club and Completely Kids. One of our newest announcements is another bricks and mortar initiative. This is a new behavioral health hospital the Methodist Health System will be building in partnership with Acadia. It'll be located in Council Bluffs, but it is meant to serve the region, so absolutely meant to serve Douglas County and surrounding. We do have behavioral health beds in Council Bluffs, 24 of them. We have a commitment to that community. As you saw in our mission statement, that communities was plural. So having those existing beds over there would not be the right thing by any means to do, is to pull out. We needed to stay committed to that community, but we wanted to expand. We wanted to increase access for the region. Going from 24 beds to 96 beds is going to be a big jump. In terms of the programming within the hospital, I wanted to share with you a couple of the things that we plan on. It'll be serving general mood disorders, depression, anxiety, bipolar disorders, thought disorders. We'll have a specialty geriatric unit, a specialty child and adolescent behavioral health unit, and we'll also serve dual diagnosis, which includes your substance abuse. Being ingrained into the community is important for this to be a successful endeavor. It will be a hospital, but it will also offer outpatient services and intensive outpatient services, partial hospitalization. We want to connect. We already have some of the doors open in terms of school programming. We want to do more outreach, specific suicide prevention training. That's a region-wide initiative, but Council Bluffs and Potawatomi County has a big challenge in their CHNA, so we're going to connect on that space. Counselor training, especially programs for veterans and military outreach, and then we also want to partner, definitely. We know the impact that this has on law enforcement, so we're going to be connecting with law enforcement. I don't know if this is a community effort or a healthcare in total effort, but I wanted to share with the board, just so you know, some of the major challenges that the health systems are having. When we're in the middle of a strategic planning process right now, we do it every 3 years, and I always lead the process and begin by talking to our leaders and to our providers, our physicians, about their major challenges. You know, what are the things that they face on the day-to-day and the year-to-year that make it difficult for them to live the mission? And at this point in time, the number one issue is resources in terms of people. Staffing, hiring, retaining, engaging, developing is a major, major issue, and we have a workforce problem. And we need to be a part of the solution. That is, you know, our lifeblood is our people. We have a lot of big bricks and mortar buildings, but the things that create experiences, the things that create care and therapies, it's the people. and we need to get that right. So we set some pretty aggressive goals. Part of it's being innovative. You saw that in our mission statement, is that we need to be innovative. We created a problem, and the reason I put this slide in here was I was doing the behavioral health section. I thought, yeah, you know, our people struggle with behavioral health too. One of the major challenges that we have is maintaining a resilient workforce. If they burn out and they turn, we have to replace them. And we're a growing organization. We oftentimes have to replace with more. So that's a challenge. So keeping people and reducing turnover and making sure people are resilient is an effort. It doesn't just happen. So one of the programs we stood up does have to do with behavioral health. And it's a point of care type peer-to-peer program. It's called RISE. It's originated out of Johns Hopkins, but it's essentially peer nurses that are skilled. They're trained in identifying someone who might be struggling with a behavioral health issue. And it might be the response of an event that they just witnessed, or it might just be a product of being tired, or the job experience. And these peers are skilled in identifying and then very skillfully working with these people. It doesn't take a licensed care professional. It doesn't take a counselor. It doesn't take a psychiatrist. It takes a peer. But we're working to get people in every care setting trained so that they can identify and assist. Some of the innovative things we're doing for, I guess, staffing and recruitment and trying to fill needs is we're working with Immigrant Legal Center and the Refugee Empowerment Center to find new and innovative ways to find people, to find talent. And we've been really successful. We're super happy with the results. These are two of the cohorts that we have, and every one of these is either a refugee or an immigrant working through their legal center and the empowerment center. We're doing it the right way, and we really are encouraged by this program. Starting early, again with that swimming upstream concept, working with local high schools. We have an upward bound program at Benson and also at Burke to develop future healthcare employees. These are high potential, low opportunity kids that we want them involved in healthcare. So we're showing them the way by letting them behind the veil, if you will, shadowing our resources, shadowing our physicians, shadowing our nurses, even our administrators, showing what healthcare really is and trying to drum up some interest so that they might seek that as a career later. This is my repeat slide from last time. Commissioner Rogers, you often ask about our stance and our position on Medicaid expansion. So I'm going to continue to repeat the message and give you an update. So before Medicaid expansion, there was a large uninsured population. Those came to us and received care through our financial assistance policies that I referenced earlier. And for the most part, that's essentially commonly known as a write-off in terms of the reimbursement or payment to the hospital. That's the write-off piece. Now that Medicaid expansion is occurring and has occurred, we have a much larger population that has insurance. They have Medicaid, and that's a good thing. They have coverage. They have access to better health care. The reality is that in terms of a government payer, the reimbursement covers about 80 to 85% of the costs of the provider. So with that, we're shifting, and this is just in how we measure it. There's a shift from what was previously written off to something that counts as community benefit, which is that loss that we take on the reimbursement, so 20 to 15%, okay? That means that 80 to 85% is new money, and you ask what's being done with it. And what's being done with it is investment or reinvestment in that community health improvement. It's the best way we can illustrate on how we're able to do early identification, how we're focusing on health equity, and through this presentation, which it's all been about social determinants of health, that's where that programming can be reinvested in. And I've used the term partner a ton of times through this presentation. I think it's ultimately because we want to be the best partner for the residents of Douglas County. It's a team effort. We can't do it ourselves, and we do need assistance and partnership and teamwork. So I'm going to end with a slide that lists our partners, and I have Steve's name up at the top. When I hired Steve, I said, you have two objectives. It is to maximize our community benefit, which was that pie chart, and it is to make a bunch of partners. We're up to 225 in the community. So this list, the font's going to keep getting smaller and smaller so we can fit it all on one slide, and that's very intentional to look this way so you can see how many of them there are. Be very happy to answer any questions for you. Hopefully this was informational and you get again the updates on the Methodist story.
Thanks, Jeff, for
You
that
bet.
overview. I appreciated all that information. One area I was going to just have you expand upon a little bit was appreciating your mobile strategies and reach out to populations that have a difficult time with access, and in particular, the street medicine program. Can you talk a little bit more about that in terms of, is that are they on the street weekly? Are they coordinating with the mayor's homeless coordinator and shelters, and how is that working?
Right, relatively new initiative and great idea to connect. It is a partnership model. It's some of the Methodist providers now have started Heal Omaha, and we directly refer to them. So in terms of their connection and frequency, it's as they are referred. The pace at which that occurs depends on the pace at which that population comes into our emergency room. In terms of their partnership in the community, I know that there's a lot of connection that they're making just simply because it's such an innovative program. There's a lot of interest. Mayor's office is a great idea.
Good. Yeah, I know we're working on that actively right now with our homeless situation and what seems to be an increasing population in need of these services.
Point of contact.
So that'd be great.
Okay.
Tamara Dwyer.
Thank you.
Yeah.
Steve. Okay. Thanks.
Question is a follow-up to Steve Hutchinson's question. On this Heal Omaha, if an individual. Oh, I. Hear me?
Now it's on.
No. Okay. Regarding the Heal Omaha program, if an individual who's homeless comes to one of your emergency care departments, logistically, I'm curious, what do they give as their address, and how do you then follow up to find them for the continuity of care?
That's exactly it. It's the patients without an address. And what they're finding is that there are common locations where they stay, and it's not an address. It's a conversation. It's a, where have you been staying the last week? Where have you been? And they find out those locations. Yeah, it is a challenge. It's not 100%. You know, there are some that disappear. But the effort to be able to connect with them, and that's the concept of street medicine, you're probably familiar with that, is exactly that, to get them in their environment so that that real conversation can be had and real change can be made.
So would a question by the healthcare provider be, I would really like to see you next week. Where would be the best place that I might find you during the daytime?
Yep.
And they might respond under the bridge down.
It's part of our social determinants of health screening process.
Okay.
That is a big piece of it, is identifying homelessness.
There we go. Thanks for the presentation. I'm interested to hear, like, if you have any initial results or data from your social determinants of health screening, and like what were the top 3 needs, and were there particular partners you looked at for those needs?
So homelessness and education were the top 2, and poverty was dovetailed with education. And those were all just the results of the location at Methodist Community Health Clinic. That's getting rolled out, and that's the data that, you know, as we get system-wide, we'll be able to really evaluate. Obviously, the homeless shelters are big connection points on that, and health literacy is another one that we're trying to make partnerships in. It's something that the pilot proved that we can do the process, that we can identify, and then we can connect, then we can follow up. And it was on a very small scale. See about 5,000 patients a year at that clinic. We see about 700,000 visits at our network wide. So to build that to scale, it's going to take a big effort. But you imagine the power of the data that you can get when you scale that from 5,000 to 700,000. And that's what we're looking forward to. That's population health. It really is. It equates to, when we build the whole thing out, it'll be about access to 305,000 people across our community. That's our patient panel size. If we look at all of our primary care offices, we care for 305,000 people. So that's the person-to-person scale.
Jeff, so you said education. When you said education, you said something else. So when you say education, you mean health literacy?
Yes.
Okay. So I'm just curious. Let me ask you this question first, knock it out the way. There's a question here. Question is, what's Methodist doing with infant health in rural areas? No, wait a minute, no, that's not the question. What activities is Methodist doing to address black infant mortality or in the urban areas? And then the second piece is, could you talk a little more about your close partnership with law enforcement? What will you be doing with them?
Okay. On the first one is, we have access with Commissioner Boyle, I think has pointed us in the right direction in our connection with IB Black Girl. And we want to definitely be active in that space, and that's our primary vehicle for that. Second question was connection to law enforcement. Has been relatively narrow but highly impactful. Again, our space in St. Sart, sexual assault, that's been kind of our leadership role in terms of partnership with OPD. We do have that in every one of our emergency rooms, and that is in partnership. And how it dovetails primarily is those are specialty care providers, not only the special needs of those survivors, but also in terms of prosecution. There's certain specimen collection that can occur, and these care professionals are specialized in sexual assault and how to perform that, so we can improve the rates of prosecution.
Your community connections piece, that has some play with the schools. You all still doing that piece? When you
community counseling program?
Yeah.
That's in the schools. Yeah, 100%. It's largely driven, I'd say 95% of that enterprise is located and in partnership with the schools. We have a few other locations with Metro Community College and then also in some churches.
I'm just curious, have you all seen any, well, you mentioned the mental health piece and depression, the school stuff, you seen any COVID-related hangover, or what you can identify with that?
Our numbers came back really strong in terms of people using the program. COVID, again, I come back to innovation. We had to very quickly stand up a virtual platform in order to do it, because the problem didn't go away. It probably made things more complex, and care was less accessible. So we wanted to stand up that virtual program. It worked. We were able to maintain it as a going concern through COVID. But once we got back into schools, once kids got back in schools, yeah, absolutely it rebounded and then some.
Well, I guess to make it clear, I'm just curious, you hear about the fact that they said there may be some depression and other stuff that has affected COVID. So I'm just wondering.
We haven't stratified the depression data. At least I haven't seen it. But yeah, that's a good question. And I was listening to your questions. I'll bring that back.
Okay. No, I appreciate you have knocked out a couple of things. So that's I'd have to say so far from who we've heard about. I mean, everybody has answered questions from the past and been there. So that's been great.
That's what we're here for.
Anything else? Say nothing. Appreciate it.
All right. Thanks so much.
Thank you for the report. Alrighty. With that said, item 5, any questions based on the reports that you all received this month? Okay, seeing none. Are there any, is there any requests for anybody to dig into anything deeper on the scheduled December administrative meeting? And if not, we'll make plans to cancel that. So if it is, I would say if somebody's got something, please, in a week. If I don't hear from you in a week, then we'll just not have that meeting in December. With that, there is nothing else. Is there a motion to adjourn? Motion by Weiss. Is there a second?
Second.
Second, Festerson. Roll call.
Yes.
Yes.
Yes. See you all in December. Thank you.